என்னன்னு ரிவர்சல்னா வரலையா? கேட்கலாமா? இதுல ரிவர்சல்னு வருமா?
போயிடுச்சா கண்ணே? ரைட்டா எது பயமோஸ்?
Hello, Dr. Kanagaven. Hello, Dr. Kanagaven.
Yes, Dr. Kanagaven, go ahead.
It is in the Google Drive. Yeah, it is in Google Drive. How to do it?
மேடம் நீங்க எதுல வச்சிருக்கீங்க மேடம்? கூகுள் டிரைவ்ல இருக்கா?
ஆமா
மேடம், நீங்க ஓபன் பண்ணிக்கங்க மேடம். உங்க பிரசன்டேஷன் ஓபன் பண்ணிக்கங்க.
ஓகே.
ஃபர்ஸ்ட் உங்க ஸ்கிரீன்ல கொண்டு வந்துருங்க மேடம் பவர் பாயிண்ட.
ஓகே.
Press the Google Drive link, it will come to your desktop. Open ஆகுதா மேடம்?
ஓபன் ஆகுது.
உங்க ஸ்கிரீன்ல வந்துருச்சுங்களா மேடம்?
ஸ்கிரீன்ல வந்துருச்சு.
சரி, இப்போ ஷேர் ஸ்கிரீன் ஒரு ஆப்ஷன் இருக்குல்ல மேடம் கீழ சென்டர்ல. நீங்க வந்து லேப்டாப்ல இருக்கீங்களா மொபைல்ல இருக்கீங்களா மேடம்?
டேப்ல இருக்கேன்.
ஓகே, அதுல கீழ வந்து கிரீன் கலர்ல ஷேர் ஸ்கிரீன் ஒரு ஆப்ஷன் இருக்கு.
ஷேர் ஸ்கிரீனா அது இருக்கு.
அத பிரஸ் பண்ணீங்கன்னா அத பிரஸ் பண்ணுங்க. அதுல இந்த ஷேர் வீடியோன்னு நீங்க பாத்துருக்க பவர் பாயிண்ட் அதுல தெரியும். அத பிரஸ் பண்ணீங்கன்னா ஸ்கிரீன்.
வெல்கம் மேடம் மரகதமணி.
மேடம்
குட் ஆஃப்டர்நூன்.
குட் ஆஃப்டர்நூன் மேடம்.
ஸ்கிரீன்
குக்கியால் மேடம் வந்துச்சா?
மேடம் ஷேர் பண்ண முடியும்.
இப்ப வருதா? அங்க வருதா? இப்போ
வரல மேடம்.
வரலையா?
Your screen is visible, doctor.
இப்பதான் விசிபிள் ஆச்சு. வெல்கம் டாக்டர் சம்பத்.
Good evening, Sampath madam.
Madam.
Good afternoon, Shanta.
Join, please join, madam.
Hi, Tara.
Who is this 1JK8Q155? So and so enter the waiting room.
No, அது
Legal issues.
Open ஆகட்டுமே அதுக்குள்ள எப்படி தெரியுது
நான் என்ன பண்ணேன்? அதுதான் பாருங்க.
Good evening, sir. President sir, Ramakrishnan sir, good evening.
Good evening, madam. Good evening.
Shanta madam, good evening. President sir, good evening.
Good evening.
Hello.
Hello. Hello, Dr. Kanagaven. Hello.
மேடம் எஸ் மேடம்.
இப்ப வருதா?
மேடம் இல்ல மேடம், இப்ப இந்த விண்டோவை ஸ்டாப் ஷேர் கொடுங்க ஒரு நிமிஷம்.
ஓகே.
மேடம் ஸ்டாப் ஷேர் கொடுத்துருங்க மேடம். அந்த ரெட் கலர்ல கீழே சென்டர்ல இருக்கு பாருங்க மேடம், அதை பிரஸ் பண்ணுங்க. ஆமா மேடம். இப்ப நீங்க என்ன பண்ணுங்க மேடம், மத்த விண்டோஸ் எல்லாம் க்ளோஸ் பண்ணிட்டு அந்த உங்க பவர் பாயிண்ட் இருக்குல்ல மேடம் ஒரு விண்டோல, அது மட்டும் ஓபனா வச்சுக்கோங்க. அப்புறம் ஃப்ரெஷ்ஷா வந்து ஸ்கிரீன் ஷேர், அதாவது ஸ்டார்ட் ஷேர் கொடுத்துட்டு அந்த ஸ்கிரீனை மட்டும் நீங்க ஸ்டார்ட் ஷேர் பிரஸ் பண்ணுங்களேன், நான் உங்களை கைட் பண்றேன்.
ஓகே ஓகே ஓகே.
green share press பண்ணியாச்சு.
கொடுங்க மேடம், ப்ளீஸ் ஸ்டார்ட் ஷேர்.
Dr. Rukia, welcome.
Anta, shall we start the meeting?
மேடம் வந்திருக்காங்க மேம். ஸ்டார்ட் பண்ணலாமா?
I think so.
One second. மேடம் கலைச்செல்வி மேடம், உங்க பசங்க யாராவது இருக்காங்களா?
என் டாக்டர் இன்லா தான் பண்றாங்க. நான் பண்ணல, என் டாக்டர் இன்லா தான் பண்றாங்க.
அவங்க இருக்காங்கன்னா கொடுங்க. இருங்க.
சொல்லுமா.
சார் ஆக்சுவலா அதுல ஸ்கிரீன் ஷேர் கிரீன் கலர் வருது இல்லையா, அந்த கிரீன்
ஸ்கிரீன் ஷேர் மேடம், ப்ளீஸ் பிரஸ் தி ஸ்கிரீன் ஷேர்.
யா ஐ பிரஸ் தட்.
அதுல என்ன விண்டோஸ்லாம் வருது மேடம், அந்த மேடமோட பவர் பாயிண்ட் வருது பாருங்க மேடம், அந்த விண்டோவை டச் பண்ணுங்க மேடம். லேசா 2-3 விண்டோ ஓபனா வச்சிருக்காங்க மேடம். ஆக்சுவலா
ஓகே. ஷேர்னு ஒரு ஷேர்னு ஒன்னு ஸ்கிரீன் காமிக்குது, அது வந்து ஐ பிரஸ் பண்ணிட்டேன். ஓகே ஓகே
சார் என்னோட ஸ்கிரீன் தெரியுதா சார்? பவர் பாயிண்ட் தெரியுதா சார்?
இப்ப தெரியுதா சார்?
ஒரு செகண்ட். இந்த மேல டியூபல் ரீகனலைசேஷன் டிரைவ் இருக்கு பாருங்க, அதை பிரஸ் பண்ணுங்க. மேல இருக்கு பாருங்க. Now it will see, you're able to see the PowerPoint.
Screen share ஆகுதானே தெரியலையே.
டாக்டர் ருக்காயில் கொஞ்ச நேரம் வெயிட் பண்ணுங்க மேடம். கல்ச்சரல் ட்ரையல் பார்த்துக்கலாம்.
ஓகே சார். ஓகே
மேடம் ஐ திங்க் மேடம் யூ ஆர் ஓகே நினைக்கிறேன் மேடம்.
ஓகே இது தெரியுதா சார்? இப்ப தெரியுதா?
ஆமா மேடம், ஆமா. ஒரே ஒரு செகண்ட் இருங்க, இப்பதான் உள்ள வர்றீங்க. ஒரே எஸ் மேடம். மேடம் இதுல அங்க மேல ஸ்கிரீன், அதாவது ஃபுல் ஸ்கிரீன் ஆப்ஷன் இருக்கு பாருங்க, டாப்ல
யா
அத பிரஸ் பண்ணிக்கோங்க.
அங்க போயிட்டு ஆட் டு ஹோம் ஸ்கிரீனா
ரெண்டு ஸ்லைடு தெரியுது மேடம். நெக்ஸ்ட் ஸ்லைடு ஆப்ஷன் ஸ்லைட் பண்ணுங்களேன். இல்ல மேடம் இது இல்ல, இது அப்படியே இருக்கட்டும் மேடம். நீங்க அந்த ரிவர்சல் பிபிடிஎக்ஸ் இருக்கு பாருங்க மேடம்.
ஆமா
அத பிரஸ் பண்ணுங்க.
ஓகே
ஓகே மேடம். இப்ப ஸ்லைட் பண்ணுங்க மேடம். அப் டவுன் ஸ்லைட் பண்ணுங்க மேடம்.
ஓகே இப்போ வருதா?
எஸ் மேடம்.
ஓகே சோ இப்போ நான் ஸ்டார்ட்
பண்ணிக்கோங்க. we have a couple of speakers before madam Kalai madam, so
Okay.
after that நீங்க திரும்ப will help you out to join madam. Please unshare.
ஓகே thank you
Madam Shanta madam, you please start the session madam.
Yes, sir. Okay. Good evening. Welcome you all for today's World Population Day CME. I welcome our President, Dr. Ramakrishnan sir, and all the speakers. Adorning the medal by President, please. Thank you, sir. Prayer by Dr. Tara. Dr. Tara, unmute yourself. Dr. Tara.
Shall we start? Indian Medical Association prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. This is a physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, the strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I may rely on thee.
Thank you, madam. Welcome address by our President.
Dear all, to welcome you to this session of World Health Day celebration by having speakers. We are at first grateful to our state president for being with us on this day, and we are also honored and thankful to all the speakers who have agreed to speak on this day. We hope we have a lively session, and thanks one and all. We welcome you all once again for this meeting. Thank you.
Thank you very much, sir. Well, sir, our President, sir.
Yes, madam. Good evening to everybody. Respected North Zone Vice President Dr. Maragadamani, Chennai South President Dr. C.V. Nadarajan, Secretary Dr. Shanta Narayanan, Treasurer Dr. Anjay Saravanan, Dr. Kanagavel, Dr. Tara, Dr. Murthy, and Dr. Yashoda, and the eminent speakers, Dr. Fatima, Dr. Nirajana Asogan, Dr. Raghavan, Dr. Sampath Kumari, Dr. Vishnupriya, Dr. Kalachari. Good evening to one and all. And thank you very much for inviting me to this CMA program, which is conducted regularly by Chennai South Branch. Indeed, I appreciate the Secretary and Treasurer for arranging this CMA program within 24 hours. Yesterday evening, I got the message by 6:30, and you collected about 6 speakers, good subjects, and which will be useful to everybody. And today's subject being the World Population Day celebration. It's an annual event observed on July 7th every year, which seeks the awareness of global population issues. It was established by United Nations in the year 1989. It is regarding to importance of family planning, gender equality, poverty, maternal health, and human rights. And we are the second nation next to China with more population. And overpopulation, the country being the Singapore, that is overpopulated country, it is followed by Israel and the Kuwait. And because of overpopulation, there will be increased demand for food, water, housing, energy, healthcare, and transportation. Increasing population is the root for major problems, including inequality prevailing in the society. Population control is the only measure where we can remove everything, establishing a progressive society. And the theme being history and significance of COVID-19. And the proverb being take care of the children that we have already instead of increasing the population. Wish you a very happy World Population Day. I once again thank you for inviting me to be part of this function. And I wish the CME program all success. Thank you.
Thank you very much, sir, for your very acceptance and guide us here. Thank you very much, sir. I thank all the speakers for readily agreed to our in a very short notice. I pay my gratitude and thanks to you all. Thank our president also for having accepted me. Yesterday only I called him and readily he agreed. Really a great moment for all of us. I request Dr. Sampath Kumari to take over. Sampath, unmute yourself.
Yes, madam.
Thank
Good
you,
evening
Sampath.
and welcome to all. First of all, I thank our state president, Dr. Ramakrishnan, and our president, Natarajan sir, and our secretary, Dr. Shanta Narayanan, for as our president told, it was arranged within 24 to 48 hours. Update 2 minutes noodles Mari sir, and secretary. Arrangement. So I welcome all the speakers. Why we planned this is the population day. 1 minute. Today's we were supposed to do it 1 week back, but due to some it was arranged very late. Today's population, India, as our president told, next to China, we have the second in the population. Our Indian population is 7.8 crore. Tamil Nadu population is around 7.8 crores. Chennai being the capital, we have the a lot of biggest population in Chennai also. To control that, we are the world population. The theme of this year is COVID-19 pandemic. During this, the theme of fertility during COVID-19. That is the theme of world population this year. Being that in mind, we have taken all topics covering the contraception. To temporary to the permanent and the recanalization, everything, we have different types of speakers talking on different topics. So I invited Dr. Tara, our Women's Wing Secretary, to invite the first speaker and introduce the first speaker.
Dr. Tara, Dr. Raghavan hasn't come yet. We'll ask the next speaker to speak first. Dr. Raghavan hasn't come yet.
Yes. Dr. Maragadamani madam irkanga. Madam,
madam,
Dr. Maragadamani madam.
Madam, unmute yourself. Madam, say a few words, madam.
Yeah, good afternoon to all. I was really hoping to attend this meeting, though I have been working night last night and also I have duty tonight, but I still wanted to attend this as the topic is interesting, and also the speakers. Dr. Rukia Fatima is a very good friend of mine, and I have known Dr. Kalachelvi. She's a pioneer in tubal recanalization, and also Dr. Raghavan to speak on male infertility. So I was really hoping that I could make it up for today's program, and thanks Dr. Shanta for arranging in a short notice. And as I mentioned earlier, she doesn't like to leave any of the days that are to be commemorated by the Indian Medical Association. It may be Yoga Day or Population Day or Nutritional Day, whatever may be the day, she tries to make it up with all Zoom meetings, and hope her enthusiasm continues. And I wish all the members to take part in such Zoom meetings to gain more and more knowledge, which will be also helpful for our day-to-day practice. So thank you once again, and I wish the CME all success. Thank you.
Thank you so much, madam. Sampath, Dr. Sampath, Dr. Raghavan has come.
Yes, he can go first. He can give
Yes,
his
sir.
lecture. Tara, madam, you can
Welcome,
introduce.
sir.
Yes.
Ma'am, hi, ma'am. Thank you so much for accommodating my request. I appreciate, and I'm so sorry for the slight delay because I was the Zoom was not starting off. I'm so sorry for that.
Okay.
So, shall I start, ma'am?
Yes, sir.
Just briefly introduce you, doctor. A few seconds. I will not cut short in your talk. Dr. Raghavan is a very highly qualified uro-oncologist currently working in Apollo Hospitals, Chennai. He has a long list of very impressive qualifications. I will be brief and just mention that he is a fellow of the Royal College of Surgeons who specialized in uro-oncology as well as robotics and laparoscopic surgery. And he has spent many years abroad in training for these super specialties. So over to Dr. Raghavan.
Thank you so much. I will do a screen share now. Hi, I hope all of you can see that.
Yes, sir.
Okay. Awesome.
Before he starts, please, all of you mute yourselves, please, so that we can hear him properly, clearly. Sir, you unmute yourself, sir.
Okay, ma'am, can you hear me now? Okay. So thank you so much for the opportunity. It was a short notice, but I thought I should join in because it's a very important topic. And therefore, I thought whatever little contribution I'm going to make to it, it will be worthwhile as well. So ma'am asked me to talk about male contraception. The first 10 slides are important. After that, ma'am can stop me at any time because I thought the enthusiasm of me thought I'll introduce to some other newer concepts as well. So, okay. So the majority in 12 countries in the world, majority of the men would use a hormonal contraception compared to women. In India, it is other way. Women are the one who uses contraception rather than men. And I do not know why. I always strongly believe male contraception is a much easier thing to do. And therefore, why it is not pushed forward is something I never understood. But nonetheless, that is the situation. The scenario in India is that amongst the knowledge in the eligible couples, that is highly read people, the level of knowledge is there, but the acceptance for spacing methods are very low, and female sterilization is the most widely used family method in spite of the effort to popularize male sterilization. A woman, for her to undergo sterilization, she has to go through anesthesia and all the antecedent risk of going into the abdomen and doing it. Whereas a male sterilization is such an easy procedure to do, and I do not know why men in India don't pick it up. If you look at the whole scenario and look at this, there is 1, 2, 3, 4th one. So the uptake percentage of male sterilization is 1.1 in urban and 1.0. That is just abysmally low. And I do not know, as I request all of you to encourage all your patients to undergo male sterilization. Reason is, it is a much simpler operation to do, simpler thing to do compared to what the women have to go through. And why are women subjected to that? I don't understand. More recognition for also the point is, it also drives the men to understand that there is a shared responsibility here. Contraception is a shared responsibility. It's not that, oh, it's a women's job. It's not the case. It reduces the burden traditionally placed on a female partner. Imagine a female sterilization camp can do 15 sterilization. A male sterilization camp can do 50 sterilization in one go. That is the difference we are here. And especially for women who cannot adapt contraception for various reasons as well. So if you look at the male contraception as a whole lot, you have spacing methods like natural methods, barriers, hormones, and intravas devices, and a lot of trials are going on. And also there are some terminal methods like vasectomy and vas occlusion devices as well. In the natural method, the most important is abstinence, coitus interruptus. The failure rate is quite high. Therefore, it is not something that everybody can adopt, and it is not a very foolproof method. Condom is the most popular method of contraception used other than female sterilization. It is made up of latex, very available, commonly available and commonly used as well. Widely used without prescription, inexpensive. In fact, free supply is there. And latex also prevents STIs as well. Especially useful when you are having problems with intolerance with IUCD. However, the disadvantage is that there is a definite failure rate with condom, anywhere between 4 to 15%. Latex allergy causes other problems. It also, people say that it reduces sexual pleasure. There are things which are added to the condom in order to make it more user friendly and things like that. That includes a spermicidal lubricated condom where the failure rates are slightly lower. Now, terminal methods, male sterilization, vasectomy, and vas occlusion methods are there. Now, vasectomy is the most commonest form of male sterilization, at least in the world. If you go to US or UK, we used to do a camp of 8 to 10 vasectomies every week, or even more than that as well. So you can cut the vas, separate it into 2 different areas, and then close it up. And there is also a thing called no scalpel vasectomy, very popular in India, especially when the camps, medical camps happen. There are a lot of steps of it. I'm going to skip all of them and say, no, it's not required. So you primarily cut the vas, divide, take a portion away, and bury the 2 ends of vas, tie the ends of the vas and bury it in 2 different layers so that they don't join together. Versus NSV, non-scalpel vasectomy, you use a sharp knife, directly make a puncture wound on the skin directly onto the vas, pull it off and cut it and leave it there. It is not as foolproof as the standard vasectomy, but in a large camp, it's okay as well. The advantages of vasectomy, after that, no routine contraception is required. Job is done. No interference with intercourse, no long-term side effects, simple procedure, very less invasive compared to a female sterilization, and allows the male partner to assume some responsibility control for the birth control. Otherwise, it seems to be only a burden of women. Disadvantages, difficult to reverse. But having said that, that's the same thing with the tubal reversal as well. And there is always a post-sterilization regret. There is some degree of complication in terms of pain and discomfort. And there is no protection of STI. For that matter, STI is not protected even when you use a female sterilization method as well. The failure rate of vasectomy is very, 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 very low, very low. The other things like autoimmune response, psychological response are there. But having said that, a properly counseled patient undergoing vasectomy will not regret that at all. Vas occlusion methods. Ma'am, you can tell me to stop anytime from now. I have finished my presentation. Now onwards, it's all newer concepts. You can ask me to stop and I'm very happy to stop. Please let me know. In the vas occlusion method, you have something called RISUG, developed from India, from IIT Kharagpur, reversible inhibition of sperm under guidance. Now, what you do is you inject a small thing into the vas and therefore destroy the vas off. Now, the problem is it is not, foolproof. There is also another thing called it was popular as saying that it is a reversible vasectomy. It is transient, painless, self-limiting, but it is not very, very effective. Then intravas device, it's a very famous thing in China. You put a plug into it, made up of polyurethane, but it is not, once again, not very popular in our country. It's supposed to be 100% effective, but it is not fully available. This is what is becoming more popular. It's called non-hormonal male pill called Gozipol, and there is a lot of discussion about that. There is also male hormonal contraception as well. Once again, everything is in experimental phase. It has not come into practice. There is a lot of discussion, but it is not widely available. Testosterone, when used in very high level, can cause azoospermia, and that can be used. But the problem is it has other side effects, namely it affects the prostate, liver, bones, and muscles as well. And then you have long-acting testosterone ester, which is effective for 12 weeks. And it can be used in combination with progesterone as well. Another latest testosterone preparation used as a monthly or bi-monthly preparation is available as well. Once again, all these things are discussed in the literature, but not in practice. This some time ago, a short while ago, came in newspapers at all. It's called the new male pill. It's less androgenic. It's primarily an estrogen pill, but it has very less side effects. But will it become popular? Answer is no as well. So then there are something called implants. Depo-Provera, which can be given, testosterone implants can be given. All of them, the side effects that the women face because of using hormones, men will face because of that as well. So hence, whilst all these things are widely discussed in academic forum, it is not used in the common practice as such. Now, as I said, it increases the muscle gain. It increases weight gain. There is increase in the muscle mass, but there is acne and oligospermia will happen as well. Once you stop treatment, they are supposed to reverse back in 2.5 to 3 months time. Once again, my experience with these things are all or nil. I don't have any experience of using them at all. This one, once again, was very popularly came in newspapers, non-hormonal male contraceptive, but it died a death immediately as soon as it is given. So I want to conclude that family planning, male have to be responsible. They have to share the responsibility with women as well. And male contraception, especially surgical contraception, is an easy method to do. As practitioner, we have to encourage people to use male contraception and not subject women to go through abdominal sterilization process as much as possible. Thank you so much, sir. Thank you so much, ma'am.
Thank you, sir. Dr. Tara, madam.
Yes.
Can introduce the next speaker.
Can I go on with the next speaker?
If any doubts, we can see. I don't see any doubts in the chat box.
I think the male hormonal contraception was the only doubt I had, but Dr. Raghavan's covered that.
Thank you, ma'am.
Thank you, sir. Then we can go to the next speaker.
Thank you.
Thank you.
Thank you, Doctor.
Sir.
The next speaker for the day is Dr. Rukyal Fatima. She's one of the upcoming young gynecologists in Chennai. And after a brilliant academic career, she's culminated in a membership of the Royal College of Surgeons. She's now working in the in the High Women and Fertility Clinic and Chetpet. So, Dr. Rukia Fatima, are you there?
I saw her now. She will be talking about emergency contraception, no?
Yes, she's talking about emergency contraception. And you can unmute yourself, Dr. Rukia. Please unmute yourself.
Can you see my screen, madam?
No, ma. No.
Share content.
Go to the slide screen and open your presentation.
I'm sharing it only, madam. Can you see it, madam?
Yes, Rukia, you can present.
Yes, madam. I'll
Yes.
start now, madam.
Yes, yes.
Please.
Okay. I'm Dr. Rukia Fatima, consultant, fertility consultant at the High Women and Fertility Clinic, Shadespet. So thank you all for giving me this opportunity today. So today I'm going to discuss with you regarding emergency contraception. It's a small presentation regarding the emergency contraception which is being used. So it is basically a method used to prevent pregnancy following any unprotected intercourse or expected failure of contraception and before the potential time of implantation. So we call this as postcoital contraception or morning after contraception also. So the basic characteristic of any emergency contraceptive, it is basically a backup plan. It cannot be used as an ongoing method because it has a very high failure rate and higher incidence of irregular bleeding. So the current scenario, why we need emergency contraception? Globally, around 42 million abortions are carried out worldwide each year, of which around 20 million are unsafe abortions, which accounts to around 1 in 10 pregnancies. Even in India, the highest number of unsafe abortions has been increased over a period of time. So actually 2/3 of the total abortions are actually unsafe. A woman dies every 2 hours due to the unsafe abortion. So when can we use this kind of emergency contraception? When no contraceptive has been used at all, or when anyone undergoes a sexual assault, when the woman was not protected by an effective contraceptive method, or when there is a concern of possible contraceptive failure. For example, it has not been used or it has been used improperly. So what do you mean by contraceptive failure? Whenever any patient takes oral contraceptive pills and 3 or more consecutively missed OCPs, if they have missed 3 or more doses in that case, or in the case of progesterone only pills or mini pills, if there is going to be 3 hours late from the usual time of intake of the POP or more than 27 hours after the previous pill. Or there's a group of pills called as desogestrel containing pill. There are also a group of POPs, progesterone only pills only, more than 12 hours late from the usual time of intake or more than 36 hours from the previous pill. And it also includes the depot. People nowadays take a lot of depot medroxyprogesterone acetate. If they have crossed more than 4 weeks late from the depot, in that case also they should take the emergency contraception. And more than 7 days late for the combined injectable contraceptive. So these are the scenarios where the emergency contraceptive are advised in case of a contraceptive failure. Other kind of contraceptive failure include any condom breakage, slippage, or dislodgement of any breakage or diaphragm of cervical cap, or in case of coitus interruptus failed withdrawal, or any miscalculation of the abstinence period, or in cases where the intrauterine contraceptive devices like copper T or hormonal like the Mirena have been expelled. So what are the types of emergency contraception now available? So there are 2 types. One is the hormonal, another one is the mechanical. Hormonals include 3 types actually. One is recently it is getting increasingly getting used among the people. So that is the omeprazole acetate. It is otherwise a selective progesterone receptor modulator. Then the second one is the most commonly available in the government scenario is the levonorgestrel containing the emergency contraception. And the least one is the combined oral contraceptive pills have also been used as the hormonal. The otherwise a mechanical emergency contraceptive is the IUD, which is the copper-T. So first one is the oliprostol acetate. It is taken as a single dose of 30 milligrams. It is available as LR1, which is more commonly used. It is a kind of selective progesterone receptor modulator. One thing we should remember about the emergency contraceptive is they are not abortifacients. They are basically interceptives. They will prevent the implantation of the embryos. So this oliprostol acetate is basically advised to use before the time of ovulation. So after the time of ovulation, it has a decreased effect because it will help in preventing the ovulation better than in the implantation. In case of people who are obese, oliprostol acetate do not have an adequate action. For example, patients with BMI of more than 35 need to take an additional thing because or be very cautious in spite of taking LR1 because there would be a decreased effect. The second one and the most commonly available is the progesterone only pills. So usually 2 doses of 0.75 milligram are advised 12 hours apart within 72 hours of intercourse, or single dose of 1.5 milligram LNG pill within 72 hours of intercourse. That is, they are most effective within the 3 days of intercourse. So failure rate is between 0 to 1% and more effective the sooner it is going to be taken. The next one is the combined ethinyl estradiol and LNG. That's called as the USP method. So oral administration of 2 doses of this 0.1 ethinyl estradiol and 0.5 milligram of levonorgestrel 12 hours apart. But this is generally not available. What is available is the 21-day pills. That is, the overall tablets are available. So overall tablet itself comes in the component of 50 mics of estradiol and 250 mics of LNG. We have to take 12 hours apart 2 doses. So that will be little effective. But the problem with the USP method or the contraceptive pills usage is they have a lot of nausea, vomiting and all. When compared to the LNG pills, the incidence of nausea and vomiting is increased in case of oral contraceptive pills. That is, 2 tablets are taken and after 12 hours, 2 more tablets are taken. Generally, patient present with a lot of gastritis and vomiting post taking this kind of combined contraceptive pill as the emergency contraception. Other side effects include they might have irregular uterine bleeding, some kind of headache, dizziness, and breast tenderness. The rarest one used as the emergency contraception is the mifepristone. The mifepristone is given as a single low dose of 10 milligram within 72 to 120 hours. And it has its mechanism as it acts as an anti-implantation agent post-coitally. During the luteal phase, it acts as a menses inducer. And in the early pregnancy, it acts as the abortifacient. But generally, the early pregnancy abortifacient dose is 200 milligram. As an emergency contraception, it is used as 10 milligram. It is more commonly nowadays used in China as a first-line method of emergency contraception. So what is the effectiveness of emergency contraception is when no emergency contraception is taken, at least 8 of them get pregnant in 100. When we use progesterone only, that is the levonorgestrel 1.5 milligram single dose within 72 hours, only 1 get pregnant. Whereas in combined estrogen and progesterone, 2 at least pregnancies happen in 100. So what is the medical eligibility criteria is actually no contraindication or delay should be taken there in using an emergency contraception. It can be used even in breastfeeding and even it can be used in patients with previous history of ectopic pregnancy. Some people we have to use with caution, those who have ischemic heart disease, embolic disorders, migraine or severe liver disease and angina. If the patient is coming to us with repeated emergency contraceptive use, then we have to counsel them adequately for a permanent contraception. So follow. So suppose if we administer the emergency contraception, how should we follow? We should inform the patient that we have to report, they have to report to us if an amenorrhea is going to be persisting for more than 1 week, or if there is going to be any acute pain or lighter bleeding in case where we have to exclude the chances of ectopic. And once they come back to us, we have to advise for a regular contraception. Then regarding the mechanical emergency contraception, the copper-T is in turn used as an emergency contraception if it is inserted within 5 days of unprotected intercourse. It is more than 99% effective, even more than the contraceptive disease. It can continue to use as an IUD as an ongoing method of contraception also, or you may choose to change to another contraceptive method in the later. So it is an effective method. It can also be used as an ongoing contraceptive method. So contraindication of using a copper T or the IUDs are pelvic infection, AUB, any kind of suspected pregnancy, uterine anomaly, and nulliparous women. So side effects, sometimes patient might present with severe pain, bleeding, chances of expulsion, and pelvic infection. So to conclude, women and men of reproductive age should be counseled about the emergency contraception. Women who have had unprotected intercourse and wish to prevent the pregnancy can be offered use of hormonal emergency contraception or copper T IUDs up to 5 days of intercourse. Users of hormonal emergency contraception should be evaluated for pregnancy if menses has not begun within 21 days following the treatment. So this is just a gist of what I've told you. So from the time of unprotected sexual intercourse, levonorgestrel 1.5 milligram, maximum effect if taken within 12 hours, and otherwise it can be taken up to 72 hours. As I told you, as in omeprazole, it also has to have a double dose in case of obese women. Then up to 120 hours, two things can be used. One is the omeprazole, but if effectiveness will be reduced if the patient has been taking a progesterone. If they have been using some other contraceptive pill and they have missed it and using omeprazole, the effect may be little reduced. The next one is the copper IUD, which can be used within 120 hours. Okay, so I always counsel them for a method of ongoing contraception. Thank you.
Thank you, Rukyal. Fantastic presentation and very crisp.
Thank you, madam. Madam, I have a request, madam, actually.
Yes, Rukyal.
Madam, actually, for reasons unknown, in government setup, we get this IPLs very easily, madam. But in the private setup, we do not get this IPLs nowadays in the easily as an over the counter. It was followed by a judgment given, but actually in other states and all, the people get this IPL very easily, madam. In Chennai alone, Chennai and Tamil Nadu, they do not get it. So because of that itself, we face a lot of unplanned pregnancies and who come later for the abortions and all. So this is just a request, madam. Don't know why the IPLs are not available with us. When even I am having a clinical fertility center on my own, and when I wanted to purchase, it was not available even with the stockist also. So I had to go to the omeprazole acetate as the LR one. That actually has a lot of. It cannot be given in feeding women. Sometimes safety is not proven yet, and sometimes patient might have some kind of nausea, vomiting more when compared to the IPLs, madam. So I just wanted to tell you so that you could consider about this, madam.
No, even in the government hospitals nowadays, that IPLs is not available. If you are going to start giving a on-the-counter means, recently we had we saw an article where most of it was bought by adolescent girls. The adolescent girls, mainly unmarried, they were getting the IPL. With that study only, nowadays, it is not available even in government hospital. It is not so easily available.
Okay.
So I think in future they will take into account. Now because the users of that to avoid the use by adolescents, it is not available frequently.
Because even we are not able to purchase it, madam, because it is more safer when compared to the LR one. But we are not able to purchase it also for the patients who really need it, madam. That's why as a small thing I told you, madam.
Yes, thank you.
Yeah. Thank you, madam.
Tara, madam, you can go with that.
The next speaker of the day is Dr. Niranjana Ashokan, another up-and-coming young gynecologist who is also specialized in endoscopy and is a member of the Royal College of Obstetrics and Gynecology. She is going to speak to us about temporary methods of contraception.
Thank you for that introduction, ma'am. Very good evening to all present. I'd like to thank for the opportunity given. I'd like to thank IMA for this opportunity. The topic of this session is temporary methods of contraception. As discussed earlier, contraception is a method that allows us to have intercourse but prevents conception. There are various types of contraception, temporary or permanent, but what's most important is it should be offered as a cafeteria approach. That is, when a patient comes to you for contraception, you should give her the pros and cons of every method instead of pushing her to one method. The choice depends upon the patient, and then there are various factors to be taken into consideration, like the cost, age, parity, side effects, contraindications. The other important factor before considering a contraception is the Pearl Index. That is the failure rate. That is how many pregnancies can happen when using this contraception over 100 women years. This is required because this helps us to determine which is the most effective form of contraception for a female. The next category is the medical eligibility criteria. So we have 4 in this. 1, this method is safe for everybody. Category 2, where the benefit of the method is more than the risk and can be considered provided there is no other method. Category 3, where the risk is more than the benefit and can be considered if that's the only method available. And category 4, it's unacceptable. So there are going to be various criteria, and it's not possible for us to remember everything. That's why there's this WHO MEC wheel that is easily available. It helps us to find the MEC category for every type of comorbidity and every type of contraception, and can help us to give the best contraception for a woman. So again, before starting a contraception, we need to know about certain history from the patient. We need to know her LMP, check her regularity of cycles, know smoking history, diabetic, hypertension, cancer history, history of STI, because some methods of contraception are not advisable with certain comorbidities. The most common temporary method is the natural method. This can be used only when the periods are regular. We can advise the patient to follow her cervical mucus or follow the calendar method, or even advise her on these apps which are readily available. These apps calculate her fertile period, which is between the days of ovulation. So when a woman is presenting with regular cycles, the ovulation is 14 days before her next cycle. So we advise her to avoid intercourse in the week around ovulation, or use a protection during this period to avoid conception. We can also give her this bead, which is the standard days method, where it has rings, and this white beads indicate fertility. So we ask the women to move the ring, and once she reaches this fertile period, she knows that she needs to be safer. Likewise, all methods have failure, and these methods have higher failure rates of about 24%. As said earlier, as said by Dr. Raghavan, coitus interruptus is another method, but yes, it is a little stressful and has a high failure rate also. The next method available is the barrier method. Male condom is available free of cost in government by the scheme of Nirod. Female condom, on the contrary, is not very widely available. It's quite costly, and it's actually very efficacious. But the problem with the female condom is it has 2 rings, and it needs some learning period to learn about the insertion, and it should be inserted about 8 hours prior to the intercourse and should be removed immediately after intercourse. The other barrier methods available are the diaphragm, which is a soft silicone like ring, which is placed inside the vagina and should be left in place for 24 hours. And the cervical cap is like a sailor's cap. So it again fits into the cervix, and it should be left for 4 hours after. So when you're using these barrier methods, there are various problems like slippage, breakage, and there are people who complain that they have reduced sexual libido and reduced usage with they're not very comfortable using this condom. But with education, we can tell the patient that it doesn't interfere much with her sexual life, and it also protects her against sexual transmitted infections. They have a failure rate of about 18% for a male condom and 21% for female condom. These were these barrier methods. The other methods available with us are the hormonal methods, and they can be in different forms like oral pills or injections or intrauterine. First, looking at the oral pills, the first available is the Malayan, which is available in government hospitals free of cost. It's a combination pill. It contains an estrogen and a progesterone. So what happens is, under the influence of these hormones, it inhibits the ovulation. And so without ovulation, the risk of pregnancy is also brought down. So when do you start these hormones is that you can start it on day 5 of a cycle, or you can quick start it like anytime during a cycle, but advise her for a backup for 7 days, 6 months after delivery in case of breastfeeding, 4 weeks if not breastfeeding, and within 7 days of abortion. So when you're starting these pills, you should tell the patient what she should expect. So she can expect headache, unscheduled bleeding, mood changes, and a minimal weight gain. When the patient, the next common question the patient has is return of fertility. The advantage of this oral pill is that the return of fertility is almost immediate. So when the patient stops the pill for a month, the next month she can start expecting her pregnancy. As I said earlier, the oral pills have two combinations, estrogen and progesterone, and the progesterone are of various generations. The commonly used progesterone in the Malayan is the levonorgestrel. The other generation, the fourth generation, is more common nowadays because it has various other advantages, like the drospirenone, which is useful in to relieve premenstrual symptoms, Dienogest, which is useful to relieve endometriosis pain, Cyproterone, which is helpful in terms of hirsutism and acne. So, Fridays is the recent OCP that has a combination of Dienogest, and it is useful in relieving dysmenorrhea. Yas, that has a combination of drospirenone. It has a 24-day tablet with a 4-day pill-free interval, whereas Malayan has a 21-day tablet with a 7-day pill-free interval. So this drospirenone helps in relieving the premenstrual symptom. Cyproterone acetate is an anti-androgen. It's again a oral contraceptive pill which inhibits ovulation. It's also beneficial because it has these anti-androgenic effects and relieves the acne hirsutism. Along with contraception, these oral pills have other benefits in terms of relieving menorrhagia, regularizing the periods, and reducing the risk of endometrial cancer by 50% with prolonged usage, ovarian cancer by 30 to 50%, and colorectal cancer by 40%. But the main thing we need to educate the patient is she shouldn't miss her pill. If it's one pill, she can take it within the next 12 hours and continue her cycle. But if it's more than 2 pills, we need to tell her that the risk of failure is more, and she needs to follow up an additional method till her next cycle. If at all she gets pregnant, you need not ask her to terminate the pregnancy if she is willing to continue. She just needs to stop further tablets. So these OCPs cannot be prescribed in some conditions because they are estrogen, which has a high thrombogenic risk. We should not give it for women who have risk of thrombosis, like women with history of VTE, migraine, high uncontrolled BP, cardiac disorder, liver cell carcinoma, and breast cancer. And they have a failure rate of 1800. A woman can be put on OCP for how much ever period she needs, but not more than 50 years because at that age, the risk of thrombosis is more. The next option available is the mini pill, which is a progesterone-only pill. They act by thickening the cervical mucus, altering the tubal motility, preventing the sperm from entering, and also prevents ovulation. The difference with the progesterone pill is when you give this pill, you need to counsel her that she can have irregular bleeding or heavy bleeding, and there can be breast tenderness because of the effect of progesterone. And there is also a risk of ectopic pregnancy because it alters the tubal motility. While with the OCP, we give a 1-day interval. With the progesterone pill, the 24-hour interval should be maintained. If there's more than 3 hours of delay, again, the pill efficacy is lost. And the women vomits, we can advise her to take a repeat dose. Progesterone-only pills are commonly recommended as an alternative to OCP in women with risk of thrombosis. However, there are certain conditions where we cannot even give a progesterone pill, and they include women with acute deep vein thrombosis, current breast cancer, anti-epileptics who are on enzyme-inducing drugs, malignant liver disease, and suspected pregnancy. It has a failure rate of about 9%, and with perfect use, a failure rate of only 0.3%. The other oral pill available is the Chaya, which is a non-hormonal and non-steroidal pill. Chaya is also available in the government hospitals free of cost. It is given as a 30 mg tablet twice weekly for the initial 3 months and a 30 mg tablet weekly thereafter. The composition of this tablet is ormeloxifene, which is a selective estrogen receptor modulator. It is anti-estrogenic on the uterus and breast and estrogenic on the bones. So it creates an asynchrony between the zygote and the endometrium and prevents implantation. It can be given even in breastfeeding mothers. It can be started anytime after her delivery. Moving on to the next mode is the injectable contraception. There are various types available, and the commonest form available in the government hospitals is the Depo-Provera under the name of Antara. It has 150 milligram of medroxyprogesterone acetate given 3 monthly. We can give a grace period of 1 week before her next injection. If the patient gets pregnant, she can continue her pregnancy. It is safe in breastfeeding, but only after a period of 6 weeks. This is given as intramuscular form. When moving on to the subcutaneous form, it's available as Cyanopress, which is again a 3 monthly dose, and other forms of progesterone as a norethistran enanthate, which is a 2 monthly injection, and a combination injection, which is given monthly, is not very widely available in India now. So when you give these injections, we can give it at deltoids, gluteal region, and the outer side of thigh. And when you give these injections, you should counsel the patient that she can expect amenorrhea, a risk of weight gain in the initial 6 months. There have been studies that said DMPA led to loss of bone mineral density, but recent studies have said that the loss is very minimal and it can be safely prescribed. But the most important thing you should tell the patient is she can have a delay of fertility of up to 1 year. Because the drug action, although it's only for 3 months, the contraceptive efficacy, the ovulation can resume even after 1 year only. We should also advise the patient for cervical screening to avoid the risk of cervical cancer. If she complains to us with unscheduled bleeding, because when you give the DMPA, the women can have spotting on and off, we can control it with prescribing an oral contraceptive pill or a mefenamic acid, which usually settles down after the initial 3 to 4 cycles. So who cannot use the injectable is, although it's only a progesterone-only injection, even progesterone is a hormone and it cannot be prescribed in women with risk of breast cancer who have history of venous thromboembolism. It is safer for women with risk of thromboembolism, but not for women with active thromboembolism. So it has a failure rate of only 0.2% with the typical use. They can be given on DMPAs for long durations, but they need to be reassessed every 2 years to rule out risk factors. The next form of contraceptive available is the intrauterine contraceptive device, which could be a non-hormonal copper T or a hormonal levonorgestrel system. In case of abnormal bleeding, it's more important to rule out malignancy by a pipple biopsy or a curettage before inserting a copper T, because malignancy is a condition that needs to be treated and we cannot allow the patient to have a copper T with a malignancy. So when do you insert a copper T is, the first thing immediately after delivery of the placenta, within 10 minutes, within 48 hours after her normal delivery, during the cesarean, after abortion. When you're giving a medical termination, we need to give it after ruling out retained products, and 6 weeks after delivery, after ruling out any chance of pregnancy. So there are various types of copper IUD available. The mechanism is by foreign body action, which prevents implantation and thickening of the cervical mucus. The differences with these copper T is their duration of action. A copper T 380, which is available in the government hospitals, is for 10 years, whereas copper 375 is for 5 years. Again, when you give a copper T, we should tell the women that it does not protect against STI. She can expect menstrual changes like increased bleeding or increased duration of bleeding in the initial 1 or 2 months, which gradually settles down, and she can experience cramps during her menses in the first 1 or 2 months. While you use the LNG IUS, what happens is it's available in different names like Mirena, Lileta, Kylina, and Skyla, and the differences being the amount of hormone released and the size of the IUS system. So in Mirena, it releases 20 micrograms of levonorgestrel for the 5 days. So again, when you insert these IUS, we should tell her that it has non-contraceptive benefits. It can relieve adenomyosis, fibroids, menorrhagia. It's also a form of HRT for perimenopausal women. There's a risk of amenorrhea after the LNG IUS system, and the risk of ectopic is less with LNG when compared with copper Ts. So when the woman is coming to us with the missing threads, what you do is first see if the copper T is in position, ensure it's not expelled. But if the woman is not sure, we cannot rule out, take an ultrasound or X-ray to ensure if it's in position. She's willing to continue and the copper T is in position, we can just follow up the same way. Otherwise, you can try removing it either by using an artery forceps or with a hysteroscopy guidance. If she's willing, again, you can give her another IUCD or else move on to another method. But if she comes with pregnancy in the early weeks and the thread is visible, it's better to remove the copper T than to continue pregnancy with a copper T in situ. Again, IUCDs cannot be given in the 48 hours to 4 weeks postpartum. Women with postpartum or puerperal sepsis or chorioamnionitis because it flares up the infection. However, HIV is not a contraindication for IUCD usage, and women with distorted uterine cavity have a risk of expulsion and so cannot be given IUCDs. Again, it can be used for the duration long time, but when you have to remove, it's essentially to be removed 1 year after amenorrhea. You cannot say amenorrhea, the woman has reached menopause and remove, because she can have her fertility for a year after amenorrhea. And after confirming menopause, you can definitely remove the copper T. When the women on HRT, you should remember that HRT is not a mode of contraception. With HRT also, a mode of contraception is essential. The other methods are the implants. Implant is a single rod containing 68 mg of etonogestrel, which can be used for 3 years. However, it's not available in India, and they have a very high efficacy rate. The failure rate of only 0.05%. There are other forms available like the patch, which is content of norelgestromin. The patch is worn for 7 days, changed every week for 3 weeks with a
Niranjana?
If the screen is frozen, maybe she's having
I
connect.
think she has completed everything, OC pills and copper tea and the latest forms
One
of
free interval to allow withdrawal used for 21 days. It can be are available in India, and it's to be remembered that. So concluding my turn is one adolescent. When the adolescent comes to us requesting for contraception, it is to be remembered that she can be counseled about contraception. We need not say that you're an adolescent, you need to be away from sexual life. Because anyway, she's going to indulge in it. It's better she's protected from unintended pregnancy, and all forms of contraception like OCPs or IUCDs or injectables are safe for adolescents, but barrier method is the best.
Niranjana, your net is not good, I think. You can conclude. Niranjana. She has to stop sharing. She has finished, but she has to stop sharing. Niranjana.
No, you're not audible and your screen is not moving.
I'll call her.
Okay. Looks like she's having some problems. Shall we go on with the next speaker? The next speaker ready?
1 minute.
One
She
minute.
will conclude. Phone login panni, she will conclude.
Yeah.
Sorry about it, ma'am. So that was with my presentation. So I'd like to conclude my talk saying that there are various temporary modes of contraception available, and with good information to the patient and good counseling, we can prescribe the best method for the patient and allow her to plan her family, plan her future, and have a hassle-free life away from unintended pregnancies and abortion. Thank you.
The next,
Thank you.
the
Thank
next
you.
speaker.
Niranjana, good presentation. Okay, we'll go to the next speaker.
The next speaker for the day is Dr. Vishwapriya. Is Dr. Vishwapriya there?
I think she was there.
She was there, but I don't see her name now. Dr. Vishwapriya, are you there?
Otherwise, we'll go to Madam.
Madam, sterilization பண்றதுக்கு முன்னாடி நம்ம recanalize பண்ணிடலாம்.
Okay. Dr. Kalaiselvi is a very familiar face with all the gynecologists in and around Chennai, and many who have.
Tara Madam Vishwapriya vandita.
Dr. Vishwapriya, are you ready? Okay, here. Dr. Vishwapriya is a senior obstetrician and gynecologist who's been practicing in Ranga Nursing Home in Madhavali. So, Dr. Vishwapriya, over to you.
Ma'am, I'm audible?
Yes,
you are audible.
Vishwapriya, you can proceed.
Okay, ma'am. Okay, ma'am. Ma'am, here, thank you everyone for giving me the opportunity to talk about comprehensive family planning. Family planning is the voluntary planning regarding childbirth. That is, birth should be according to desire and not.
Vishwapriya, கொஞ்சம் voice increase பண்ண முடியுமா?
Okay, ma'am. Okay, ma'am. Types of contraception is. Ma'am, I'm audible?
Yes, yes.
Audible.
The permanent methods, there is female sterilization. Sterilization. In female sterilization, there is tubectomy, and male sterilization is vasectomy. Female sterilization involves ligation with or without resection or blocking of both the fallopian tubes. There's tubal ligation methods. We have Pomeroy's method, Irving technique, Uchida technique, fibrectomy, Madlener, Parkland, and vaginal tubal ligation. Commonly, we are using Pomeroy's method. In Pomeroy's method, a loop is made by pulling a portion of the tube by artery and the base of the loop is ligated with a chromic catgut. The top of the loop is cut off. In modified polymerase technique, a silk stitch is applied to the tubal stump medially. In tubal occlusion, we have electrical methods and non-electrical methods. Electrical methods, we use cautery, and non-electrical methods, we use elastic bands and spring-loaded clip, which is Halka clip and Fish clip and Fallopring. The timing of the procedure, we can do at interval sterilization done within 7 days of menstrual period, postpartum sterilization, 24 hours to 7 days of delivery, sterilization along with MTP, sterilization following spontaneous abortion. Laparoscopic tubal ligation should not be done concurrently with second trimester abortion and in postpartum period. What are the standards for female sterilization? Who can perform the procedure? Mini lap can be done by a trained MBBS doctor. Laparoscopic sterilization can be done by a DGO, MDOG, MS surgery trained in a laparoscopy. Case selection. Should be a married female, 22 to 49 years, at least one child more than 1 year of age. Spouse must not have undergone sterilization. Should be in sound state of mind. In case of mentally ill, should be certified by psychiatrist. What are the clinical process? Counseling, how we should counsel the patient. All available methods of family planning should be discussed and it should be a voluntary decision to be taken by the patient, should be counseled in the language which the patient can understand, and the complications before, during and after the surgery should be explained in detail, and we should also tell the patient that sterilization will not affect her sexual pleasure, does not affect her routine day-to-day activities, and the reversible of surgery is also possible. What are the pre-operative assessment we should do? Pre-operative assessment, we should take the proper history, including her age, medical history, surgical history, and routine blood investigations, hemoglobin, urine, sugar. Anesthesia, we can give a local anesthesia. The local anesthesia which is recommended for sterilization is given below. In case of non-cooperative patient, we can give general anesthesia in obese patient and patients who are allergic to local anesthetics. How to monitor the patient during the procedure? Communication must be maintained with the client throughout the procedure, and pre-op pulse rate, BP and respiratory rate should be monitored every 10 minutes. Intra-op pulse rate, BP, respiratory rate every 5 minutes, and post-operative vital should be monitored every 15 minutes till patient is awake. Surgical techniques, how we can do the procedure. The client's bladder should be empty. Pre-operatively, patient should be nil oral by mouth for 4 to 6 hours, and she should take a bath, and she should wear loose dress, and the client's bladder must be empty before entering the OT. The fallopian tube should be clearly visualized up to the fimbrial end. Site of occlusion should be 2 to 3 centimeters from the cornwall end in the isthmal portion. 1 centimeter of the tube should be excised. Skin incision should be closed with absorbable or non-absorbable suture. Post-op care, patient can be discharged at least 4 hours after the procedure when the client is awake, when the patient has passed urine and can walk and eat. Should be evaluated by the doctor before discharge, and patient should be accompanied by a responsible adult to the home. If necessary, analgesics and antibiotics can be given. Post-op instructions can resume work after 48 hours. Normal day-to-day activities she can take after 2 weeks. She can have her normal diet, and patient should be visited by a female health worker within 48 hours after surgery. Second follow-up on day 7 of post-operative day for suture removal. Third follow-up 1 month after surgery. What are the complications we can expect? Intra-op complications and post-op complications. Intra-op complications, patient may have vomiting, nausea, vasovagal attack, uterine perforation. In case of uterine perforation, if there is a bleeding, it should be managed either by laparoscopy or laparotomy. If there is no bleeding, we can watch the patient for 24 hours. If there is any mesosalpinx bleed, it should be dealt with laparoscope or laparotomy. Injury to urinary bladder, enclosed in 2-layer sutures and self-retaining catheter should be placed for 7 days. If there is a bowel injury, it should be repaired immediately. What are the post-op complications? There may be a wound sepsis, there may be a hematoma. If there is a small hematoma, can be dealt with analgesics. If there's a large hematoma, it should be opened and the blood should be drained. Intestinal obstruction, paralytic ileus, if we suspect, we should hospitalize the patient and treat accordingly. Failure of operation leading to pregnancy should be informed to District Quality Assurance Committee. From there, they will inform the State Quality Assurance Committee. And these are the National Family Planning Indemnity Schemes with effect from 2013. In any failure of sterilization, these are the following compensations that are given by the government to the patient. Death at hospital within 7 days of discharge, 2 lakhs. Death following sterilization, 50,000. Expense of treatment of medical complications, 25,000. Failure of sterilization, 30,000. Doctors' facilities covered for litigations up to 4 cases per year is 2 lakhs. Standards for male sterilization, conventional vasectomy and non-scalpel vasectomy. Trained MBBS doctor can do the procedure. Case selection should be ever married, below the age of 60 years, should have at least 1 child who is above 1 year. Spouse must not have undergone sterilization. Mentally ill must be certified by a psychiatrist. Counseling, it should be done that it is the permanent procedure, and it clinical assessment same as the female. All the regular history taking should be there. Timing of the procedure, anytime if patient is healthy, we can do the procedure. Informed consent, it is very important. Informed consent should be taken from the patient. Pre-operative instruction should be given. Patient can have a light diet in the morning of the surgery. Pre-medications, if necessary, can be given. Surgical technique, conventional vasectomy, incision should be made 2 incisions, one on either side of the root of the scrotum or 1 incision in the midline. Site, it should be the mid-scrotal part of the vas to be removed. Excision of the vas, 1 centimeter of the vas to be excised. The cut end of the vas must be tied with a 2-0 silk and the spermatic fascia should be interposed between the cut ends. Closing the skin incision with the non-absorbable suture and covered with the sterile gauze and scrotal support. In non-scalpel vasectomy, anesthesia is a local anesthesia. Site at the midline at the junction, upper 1/3 and middle third of the scrotum. Vas is fixed with the vas fixation forceps and vas is dissected out and ligated and excised. The same procedure is repeated on the other side. Skin wound is, puncture site is inspected for any bleeding. Wound is dressed with sterile gauze. Discharge 30 minutes after surgery. When the vitals are normal, patient is ambulatory, should be evaluated by a doctor before discharge. Post-op instructions, normal work after 48 hours, normal activity after 1 week, can take bath after 24 hours, 7 days for suture removal, and 3 months patient should do semen analysis. What are the complications? Intraoperative complications, vasovagal attack, convulsions, and injury to testicular artery. Immediate complications, swelling of the scrotal tissue, which can be dealt with analgesics, ice packs, hematoma, the same as ice packs. Infections, antibiotics can be given. Immediate complications, late complications, sperm granuloma, psychological problem, failure of the vasectomy. Thank you, everyone.
Nice, Vishwapriya.
Thank
you.
you.
Have covered everything.
Thank you, ma'am. Thank you, ma'am.
The next speaker is Dr. Kalai, who is a senior obstetrics and gynecologist who has been in government service and retired as the head of the Department of Obstetrics and Gynecology. And
Vishwapriya, you can stop sharing, then only madam can share.
And she was head of the department of microsurgery in Keele Medical College, and also as the former head and professor, head of the department of OBG and microsurgery in Mada Medical College too. She presented numerous papers and is a national level trainer in microsurgery. Dr. Khaled, shall we please?
Yeah, yes.
Yeah. Can you see the slides now?
Can you see the slides?
Yes, yes, madam.
Okay. I should thank the organizers of IMA South Chennai for giving me this opportunity to share my views on tubal recanalization. Can you hear me?
Yes, madam. Yes, madam.
Okay. Tubal microsurgery. Here, the female sterilization is a key constraint of National Family Planning Program of India, but they are nowadays performed in young women of low parity. She told that sterilization age group 22 to 49 years. So many women come with the age of 23 years with the 2 children. She underwent sterilization, but she lost both the children. So there comes the need of the tubal microsurgery. Due to unforeseen circumstances, national calamities, we had tsunami and also Kumbakonam fire accident. So there they lost both the children or loss of only child. There is a need for reversal of sterilization. So with the microsurgical tubal recanalization, we can improve the pregnancy rate over 60%. However, this tubal microsurgery is being taught and practiced less and less, eliminating this credible surgical option in most centers because of the advent of IVF. What is the history of tubal microsurgery? In 70s, Kurt Svalin from Sweden, he was the first person to introduce microsurgery in gynecology in 1962. Then Victor Gomel, who is the pioneer of microsurgery, who did tubal microsurgery for primary infertility and also for reversal of sterilization. Then comes the Winston and Dichony and Dubisser. What is the basis of microsurgery? Magnification is the hallmark of microsurgery. You have to use the microsurgical instruments, fine suture materials, atraumatic surgery, using the cautery, accurate eye-hand-brain coordination. So magnification, you can use the loop, but here the fixed magnification with the 4.5x. The advantages are cheaper and transportable, but disadvantages are more. You have to do the surgery with the fixed position. That too, this is the pelvic surgery, not the eye surgery. So you can get fatigue, headache, and muscle strain. So when you use the operating microscope, it will be ideal when comparing this loop. So microsurgical, coming to the microsurgical instruments, the length of the instruments should be at least 12 to 14 centimeters. Can you hear me? Can you see the slides?
Yes, madam. We can hear and we can see the slides.
Okay, thank you. So the instruments, the length of the instruments again 12 to 14 centimeters, and the needle should be not the routine needle, it's the spatulated taper point needle, and suture material 80 ethylon. That is very important thing. Then diathermy is very important to get the hemostasis, both monopolar for cutting and coagulation and bipolar for the bleeding vessels which are present in the 6 o'clock position and also 12 o'clock position of the fallopian tube. So previous sterilization, again, we told the indications are loss of both children, loss of only child, and change in marital status and regret of sterilization. Some people, they come. So selection of patients, when comparing the pregnancy rate with the IVF, here the 45% pregnancy rate in the age group of 40 to 45 years. So with the tubal surgery over IVF. So coming to the sterilization, she has told so many types of different techniques of sterilization. But even if you take the laparoscopy, you can use the fallope ring, Hulka clip and Filshie kit, single burn technique and multiple burn technique. Which gives the most success rate means fallope ring, because the fallope ring can be applied, it should be applied at the isthmial region. So the damage of the tube, it is about only 1 centimeter or maximum 2 centimeters. It definitely you will apply only the ischemial region. But nowadays they are doing the single burn or multiple burn technique. So the length of the tube is about 12 centimeters, 10 to 12 centimeters, whole fallopian tube. The remaining after surgery, the length of the tube, it is about only 2 to 3 centimeters. Even with the laparoscopy, with this type of technique, if you do it, then the success rate will not be there. Then pomeroid technique, again, modified pomeroid technique. We go so many cases we do with the pomeroid technique only. Fimbriectomy, we talk about the type of sterilization, but it is not the type. When you think of reversal in young women, we should not do the fimbriectomy, because without the fimbria, it is very difficult actually to do the reversal surgery. This is the analysis for over a period of 9 years when I was in KMC. My experience with 18 years in KMC in the same department. Here, the pomeroid technique, many people we did reversal of sterilization who had pomeroid technique only. But the success rate or pregnancy rate you can see only with the laparoscopy only, even though the number of patients 141, the success rate is about 68%. So coming to the different types of technique of sterilization, you should know what is the standards of sterilization, which was given by Government of India. So we, that is about, we did about 36 workshops of 4 days duration of standards of sterilization, which was funded by Government of India from 1990 to 96. So the sterilization should be done in the ischemial region, that is 2 to 3 centimeters from the conva. The tube should not be crushed or clamped. Less than 1 centimeter of the tube should be excised, and 10 chromic adget should be used. So coming to the reversal surgery, what is the interval between sterilization and reversal surgery? Again, within 1 year, if they come up, because sometimes they say the child dies, with the only one child, they would have undergone sterilization. When they lose the child, actually after 3 or 4 months, they come back within 1 year. So within 1 year, if you do, the success rate is 87%. What happens after 5 years of sterilization? There are epithelial changes taking in the tube. So the cilial damage occurs in the tube. So that's why the success rate goes down. What are the preoperative? Like this is the open microsurgery. So you have to do like laparotomy, proper history taking, and then what are any other medical conditions, and also seminal analysis. Clinical examination is very important. So you have to do the bimanual pelvic examination, ruling out other gynec pathology, and seminal analysis is a must. Usually patients will say, we had children, 2 children. Now we have come for tubal surgery, reversal. But even then, you should insist that similar analysis must be done. Then important specific investigation, you have to do the diagnostic laparoscopy. So what is the need for diagnostic laparoscopy? Because where is the site of sterilization? You can visualize the proximal segment of the tube and also the distal segment of the tube. Again, this is our study showed when a patient who had pomeroid technique, when you do the diagnostic laparoscopy, only 5.3% of cases had sterilization at the isthmus, 53% had at the distal ampulla. But with the laparoscopy, the ischemial region was the site of sterilization, 80.6%. Then presence of adhesions, you can see associated PCOD to rule out tuberculosis also before surgery by doing this diagnostic laparoscopy as the preoperative specific investigations for tubal surgery. What are the procedures? Tubotubal anastomosis for the mid-tubal block and tuboconval anastomosis. In a case of sterilization, tuboconval anastomosis, sometimes we put the ring towards the conva. There comes the tuboconval anastomosis. But it is not the case of primary infertility, it is only the reversal surgery. Here there is no pathology. So the success rate even with the tuboconval anastomosis for reversal of surgery, it is more. Then fimbrioplasty for phimosis and cuff salpingostomy. If the patient had actually the fimbriectomy, there is nothing we can do, only the cuff salpingostomy and also for hydrosalpinx. So what are the things, principles of microsurgery? So gentle tissue handling to minimize the tissue damage and hemostasis with the diathermy. So diathermy is very important, and fine microsurgical instruments and Here comes the complete excision of the pathological tissues. So fibrous tissue, that is the thing proximal, formation of the proximal segment and the distal segment. You have to excise and trim the cut end of the tube. So that portion is very important. If you do the anastomosis with the fibrosed tissue on both sides, then it will be a failure only. Then precise alignment and approximation of the proximal and distal tubal segments. Pelvic cleavage. After doing the surgery, you have to remove the blood clot so that by the pelvic cleavage with the ring-lactate solution you can. Because this blood clot, it form and form the adhesions. Adhesion formation, thereby the failure of reversal surgery occurs. Then adhesion prophylaxis. That is, you have to give the 32 milligram decadron into the peritoneal cavity after surgery, reversal surgery. What is the surgical technique? This tubal surgery means this you can see the mesosalpingeal suture. So first you prepare the proximal and distal segment. Here, after approximating the mesosalpinx, the free ends of the both the proximal and distal segment, you have to give methylene blue. Put the methylene blue and see the patency of the proximal and distal segment. Then first suture should be the 6 o'clock position, muscularis to muscularis. This is the two-layer technique. First, you have to take the bite, muscularis to muscularis, 6 o'clock position, 12 o'clock, and 3 o'clock, and 9 with the 8-0 ethylon. Then the second layer is serosal layer. So this is the two-layer technique. The muscularis, you should not go into the fallopian tube. Tubal lumen you should not go. But unlike this vasovasostomy, but you have to go into the lumen when you do the vasovasostomy. So what are the types of anastomosis? Reversal surgery. Ischemic anastomosis. Here it gives the maximum success rate about 80%. Because the muscularis portion is more, approximation will be good. The length of the tube will be more than 6 centimeter. So the success rate is more with the when the sterilization done at the isthmial region. So this is ischemic anastomosis. Then ischemo-ampullary anastomosis. Here the luminal disparity will be there. So at the isthmial region, at the 12 o'clock position, you can just extend the incision, that is fish mouth. Thereby you have to do the same 4 cardinal sutures and serosal layer. But the incidence of ectopic pregnancy is more when comparing the ischemo-ischemic because of the luminal disparity. Then ampulla-ampullary anastomosis. Here again, what is the difference between ischemo-ischemic and ampulla-ampullary means? Here when you cut the tube, actually the mucosa will be coming out from the tube. So you have to push it inside, not cut the mucosa. Otherwise, intertubal adhesions will occur. So you have to do the ampullary anastomosis. You have to push the mucosa inside the tube and do the anastomosis. Then tubocondyval anastomosis, it is very difficult because the condyval diameter is about only 1 millimeter. So the tubocondyval anastomosis, only if it is actually done, the fallopian was applied towards the conva only, it becomes the tubocondyval anastomosis. But these patients, they conceive, unlike infertility patients where the pathology is there. Then phimosis, of course, this is just you put the cautery and open the fimbrial. The fimbrioplasty also, here the fimbrial adhesions. Cuff salpingostomy, when the fimbriectomy was done, it is the ampullary cuff salpingostomy because you're cutting the blind end of the ampulla because already fimbria is cut. So fimbriectomy done. So open and then avert it. So form a cuff. So this is again cuff salpingostomy. Here in our study is the ischemic anastomosis maximum 76%. The tubal length is very important after reversal surgery. So 6 to 8 centimeter. It should be more than 6 centimeters after reversal surgery. So 6 to 8 centimeter length maximum pregnancy rate and more than 8 centimeters, of course, 81%. So the length of the tube is important thing after reversal surgery. For that only we are telling again and again, ischemial is the portion that should be the site of sterilization. Interval between recanalization and conception. Here within 1 year, actually Like other surgeries, cesarean and all, we will tell the patient, don't conceive for 1 year. Here, the surgery, we will say, after 2 to 3 months, she can conceive. Sometimes even next cycle, patient will come with the pregnancy. So within 1 year maximum pregnancy rate, or even 2 years, the maximum pregnancy rate. So what are the do's and don'ts when you do the reversal surgery? Do's means good exposure of the surgical field. So the incision for microsurgery, open microsurgery, not the small incision. You have to put the sufficient incision, skin incision, no abdominal packing. Irrigation throughout surgery. Heparin to ringer lactate solution. You have to irrigate throughout the surgery over the tube. And patency, it is very important. Many of the patients, 98% proximal and distal segment, before anastomosis, we have to put the methylene blue dye and see the patency. And then 2-layer anastomosis, avoid mucosa. And again, after anastomosis, you have to check the patency after anastomosis, whether the dye coming through the fimbria. Intraperitoneal installation of dexamethasone, 32 milligram. Don'ts means no abdominal packing. You should not pack, no retractor, no swabbing of the tissues, only irrigation, no mopping. Tube should not be cauterized, no tubal splint, because again, maybe the intratubal adhesions may be forming and there be the failure. No hydrotubation. Previously in 90s, we used to do the hydrotubation on 3rd post-operative day, but everything will be stopped. There is no need for hydrotubation at all. So to do the proper microsurgery, tubal microsurgery, because you are seeing under the microscope, you have to have the hand-eye coordination. So you need training in microsurgery. So start with the glove suturing and also the rat uterine horn. This is the rat uterine horn. It has 2 horns, but it is like our fallopian tube, 2 layers. So previously we used to have during the workshops, we used to have the rat uterine horn. But nowadays it is very difficult because of ethical committee clearance. We have to get the ethical committee clearance, animal ethical committee clearance. So alternatively, umbilical artery, you can take umbilical cord, dissect the umbilical artery, you can do the anastomosis. So this is the workshop, Government of India of 100. Microsurgery workshop I conducted 10 in KMC, and we had 36 standards of sterilization workshop from the Taluk headquarters and district headquarters in 90 to 96. So there is actually no RCTs are available in the use of magnification, that is the operating microscope and loop and all. No evidence of benefit or advantage when lap was compared to laparotomy. So best results, actually trained surgeon, that is more important. Success rate is laparoscopic sterilization is the highest. Best anastomosis is the isthmic anastomosis. Best results is the more than 6 centimeters length of the reconstructed tube. Maximum pregnancy rate within 2 years of recanalization. And then I would like to tell about 2 or 3 lines about when comparing the reversal surgery with the IVF. That's why the importance of this. American Society for Reproductive Medicine Committee, with the retrospective study, they reported comparing IVF with the surgery. Less than 37 years, there is definitely significant higher cumulative pregnancy rate and cost also less for microsurgery than IVF. Okay. But we are talking about the pregnancy rate. What about the pregnancy outcome? In IVF, definitely there is increased incidence of spontaneous abortion, multiple pregnancy rate is increased, and preterm birth and low birth weight. But in microsurgery, there is no increased incidence of spontaneous abortion, or these are all the complications. It is not related to the surgery at all. Coming to the microsurgery, open microsurgery and laparoscopic microsurgery. When comparing it, hospitalization is definitely, it is half with the laparoscopy, but the ectopic pregnancy rate is increased 3-fold when you do the laparoscopy, and they can't use the 8-0 Utilon, and also it is not a 2-layer anastomosis. Just they will approximate the tubal segments, both the tubal segments. But the pregnancy rate and birth rate, live birth rate, similar in both the cases. Again, when you compare the robotic surgery and open microsurgery, definitely there is increased operative time and cost with the robotic. But the pregnancy rate is similar in both. So, is it still useful to teach and learn tubal microsurgery? No publications have been able to demonstrate that IVF is superior than microsurgery in a prospective trial. But the results are depending upon the surgeons and the patient selection in microsurgery. But the results in IVF, it differ in different centers. So training should be an integral part of subspecialty training in reproductive endocrinology and infertility. It is mainly the reproductive medicine. So the success of microsurgery for the surgeon and also for the patient is dependent upon the patient's perseverance and perfection. Then only you will get perfection when you do the microsurgery. Thank you again, once again, for giving me this opportunity to tell few words. Reversal.
Thank you, madam.
Thank you.
So nice. Very good presentation. Always, madam is fond of recanalization. She is never for IVF. Very good. She has done lot of, we have done workshops with her in Oxy also.
Yeah, Oxy also we did.
We have done workshops.
Yeah.
Anyway.
Hello, Kalai. How are you?
Yeah.
Hello. I'm Rukmani here. You have done a lot of recanalization after the tsunami, no? That gave very
tsunami
good results.
20 cases I did, madam.
Yeah, and that gave very good results. Right?
Yeah, fire accident also I did.
Yeah, fire accident, right.
That time in 2006 and 2004.
Yeah, I remember that.
So it was Government of India funded many people. So KMC became the apex center to train other centers also. It is the regional center. The other centers are Calcutta, Bombay, Delhi, and Chennai. So KMC became the apex center to train others. So from other centers, the people will come from Bangalore, Amritsar, Rohtak, and Cuttack and all. Because everywhere the department is not separate like ours and KMC. Everywhere OG people, they only do. So per year, they will do about 10 cases or 15 cases. Here we do per month, 8 to 10 cases we will do. So the number of cases we are doing becomes, so Ministry of Health and Family Welfare, they made me the master trainer to give training for the other centers of excellence in other places also. Thank you so much again for giving me this opportunity after a long time. Just I wanted to tell about it.
Thank you, ma'am. Thank you.
The last speaker of today's session is our own Dr. Sambat Kumari. I'm sure she needs no introduction. However, we all know that she's a very active member of our Chennai South as well as Oxy, and as a national level chairman of the Adolescent Committee. Now, today she's going to talk about the medical legal aspects of contraception. And there are legal aspects. You've had husbands coming and fighting because we sterilized the wife. So all these things will be addressed by her.
Thank you, madam. Thank you, Tara, madam, for the nice introduction. First of all, I thank Dr. Shanta, madam, for organizing the 2 minutes noodle World Population Day project within 48 hours. So we had all talks starting from male vasectomy, emergency pills, and contraceptive methods of temporary and permanent, finally recanalization also. So what are all the legal issues in contraception? Normally there is no legal issues with the contraception, but when we do, what are we going to do with the MTP Act, POX Act? There are a lot of factors. What are all the legal things we should know? So what is MTP Act? Before 1971, they were considered that abortion is a criminalized factor. But the medical termination of pregnancy was passed in 1971. And after that only, we were permitted to do the abortions, that too by the registered medical practitioner. What is MTP Act? Nowadays, we have a lot of litigations. So as per rules and guidelines only, we have to do everything. This MTP Act mainly is to improve the maternal health scenario and legalizes abortion services and promote access to safe abortion services and decriminalizes the abortion seeker. Already, I think Dr. Emergency contraceptive speaker has mentioned about what is safe abortion and how many unsafe abortions are happening in the world. For that only this MTP Act has come. So the legal framework is MTP Act, MTP rules, MTP regulations. This act tells when and where the pregnancy can be terminated and what is the government rules and regulations. And the MTP rules is on who can terminate the pregnancy, what are all the instruments needed, what is the approval process. And the regulation is how to maintain the records. And once it is the center is approved, means how it has to be maintained. This is the legal framework which you need. So the indications, just like that, you cannot do MTP for all patients. If the patient is going to continue, it will produce physical or mental health problem to the mother, then it is one indication. Then physical and mental abnormalities for the fetus, if the congenital anomalies, babies, whoever it is, and the mother is a mentally retarded mother like that. And the contraceptive failure in married couple and the pregnancy caused by the rape. So these are all the indications where we can do the medical termination. And the legal abortions, when it is considered as legal abortions, everyone are doing, whether it is legal or illegal, that is important. The termination done by a medical practitioner approved by the act that we have. What are all the acts? Already Dr. Vishwapriya has told. Anyway, I'll have in the next slide also. Termination done at a place which is an approved center, and termination done for conditions which was mentioned by the MTP framework. So this is only the legal abortions. And who can do? That is the experienced obstetrician and gynecologist, or whoever is experienced in ONG for 3 years and completed 6 months of CRRI in ONG, and who have done registered medical practitioners who have done 25 cases in the approved center. This is the guidelines. These are all the people who can do the MTP. And when it can be done, just like that for 26 weeks, 24 weeks like that. So it has to be done normally. It should not exit only in the first trimester up to 12 weeks. When you are going to do for 12 to 20 weeks means you need 2 doctors' opinion. That is as per 1971 MTP rules. The continuation of pregnancy may involve the risk of the mother, and it can produce any physical or mental problem to the mother or the baby. And the no pregnancy of woman has not attained the age of 18 years. So this is, if they have attained 18 years, less than 18 years means the rule is different. So 12 weeks means 1 doctor, 12 to 20 weeks means 2 consultants is needed for MTP. And where it has to be done, as we told, the centers which are approved, that is the government hospital where they are already all facilities are there, and in a place approved by the approved for this purpose by the district level committee constituted by the government with CMHO as chairperson. So the center should be recognized that they can do the MTP Act. Then only it is considered as legal and only they can do. What are all the things needed? Up to 12 weeks, labor table, drugs and IV fluids, resuscitation and sterilization equipment, backup facility for treatment of shock, and transport of the facilities needed. If it is between 12 to 20 weeks, then we need the operation table and instrument for performing abdominal or vaginal procedure. Anything if needed, they may open for that. Then the anesthetic equipment. These are all the things necessity in the hospital to do the MTP. How the approval? They have to apply. Application form A has to be done and it has to be verified by CMHO. And the CMHO recommends the approval to the committee, and the committee considers the applications and the form B is given. Then it is mentioned that a particular center can do the MTP. The place will be inspected within 2 months of receiving the application, and certificates will be issued within 2 months of inspection. Still the procedures are going on. If you apply within 2 months, they will come and you will receive the certificate within 2 months. If any deficiency is found, they will have the checklist, and the deficiency has to be rectified within 2 months, and they will again review the center. And the inspection is the CMO will inspect for the safe and hygienic conditions to conduct the MTP. And if anything present, they will inform, as I told you earlier. If it is unsafe and they feel that the place is not good for surgery and it is not a good place for MTP, they have the rights to cancel the certificates which has been given. So they will come for frequent inspection to approve that. The penalties, what are all the penalties? Penalty of 2 to 7 years in prison if termination is performed by non-registered medical practitioners or the center which is not approved for the MTP. In that cases also, we have the penalty. So who should do, where should do, when it should be done, what are all the hospital facility, and how to get the approval and how to get the certificate. Everything is very, very important to do the medical termination of pregnancy. See, nowadays the anomalous scan we take only from the 18 to 20 weeks. So there was an amendment was passed, amendment bill in 2020. Now recently we had that MTP revised act. As per the revised act, what is this? This applies only to the married woman. Here in this 2021, that is the recent act, even the unmarried woman, they can also be done for the MTP. That is for MTP Act. And the gestational age limit was 20 weeks. As I told, 12 weeks, 1 doctor, 20 weeks, 2 doctor. But now it has been extended up to 24 weeks. This 24 weeks is not for everyone. This is for the rape survivors. And if there is any anomalous that is lately diagnosed in 22 weeks, 24 weeks. Only for this purpose, the gestational age has been extended from 20 to 24 weeks. And the medical practitioner, as I told earlier, for 12 weeks, 1 medical practitioner, for 20 weeks, 2. Now, again, it has mentioned that even with 1 medical officer, up to 20 weeks, you can proceed. And for 20 to 24 weeks, that is the extension period for 4 weeks. There you can get the opinion of second registered medical practitioners, doctors. And the medical board, if it is above 24 weeks, and if you have an emergency or any problem to be discussed, they can have a medical board, local medical board. If it is a medical college, they can have pediatrician, psychiatrist, anesthetist, and everyone, dean and someone from the family welfare, and they can form a committee and they can go with the MTP. This is the proposed amendment. Previously, when the confidentiality is given, the fine was up to 1,000. Now it has been mentioned that even the imprisonment can be given for 1 year. This is the latest MTP Act. So as per this, up to 20 weeks, 1 doctor is enough. And MTP can be done up to 24 weeks in case of rape case and the anomalous baby. So this is the amendment. Up to 12 weeks, 1 doctor, now 1 doctor. Up 20 weeks, again 1 doctor. 20 to 24 weeks, 2 doctors. More than 24 weeks, medical board, which with they can decide. And any time during pregnancy, if there is an emergency, means 1 doctor, the emergency cases, if the other doctor is not available, they can proceed. And then they have to form a medical board, and whatever they have done, they have to fulfill it. Why it is done, they have to give the explanation. So the bill allows the constitution of a medical board, which includes that medical board. I told no, who are all the persons should be included in the medical board. That is the experts such as sonologist, radiologist, gynecologist. In our hospital and all, we included dean also. So the any hospital's dean is the main person, so he has to be included in the medical board and the HOD of the OG department. The medical board is authorized to examine the need of the termination if the upper limit of 24 weeks are passed. So this is the latest amendment. So 1971 MTP Act, now we have the 2021 amendment bill. For whom this already I have told, where the 24 weeks can be done, the rape survivors, pregnancy caused due to incest, and a woman with a differently abled, that is mentally retarded person, and a minor, and abnormalities detected in the baby. These are all the persons where it can be done. So this is the situation where I already told, unsafe abortions, 22 million are taking place per year, and 7 million is conducted in India. Of this, 50% abortions are illegal, and the rate of maternal death due to unsafe abortion is 8%. So this illegal abortions we have to avoid. Then only we are talking about the contraceptions and the methods of contraception and everything. So rather than going for an abortion, we should counsel the patient and they should have the contraception. See, this is India has one of the highest maternal mortality rates in the world. That is 35,000 lives. A large percentage of death due to unsafe abortion is 36.6%. This is with the unsafe abortion mortality, not with others. So for this only in 2003, again, they have introduced the medical abortions. Medical tablets was injected like mifepristone and misoprostol that was given from the MTP Act 2003. That is, in these cases, termination of the early pregnancy up to 7 weeks by using RU486, that is mifepristone, and with the misoprostol, that too prescribed by the registered medical practitioner and as per the MTP Act. So this, if you are going to give the medical abortion, medical pills also up to 7 weeks, the mifepristone and the misoprostol, they should be the registered medical practitioners. Though the act is there, before you go for that giving the pills, you should have an ultrasound report, whether the baby is in the tube or whether it is in the uterus. The ultrasound should be done earlier. And after a product has expired, again the ultrasound should be done to do the retained products. So this was introduced in 2003. The medical abortion using RU486, that is mifepristone and misoprostol by registered medical practitioners, even from site not approved, provided that if the medical practitioner is giving the tablets, means they should also give where if the patient is having the complication, where she should come, because this tablets can be given as an OP procedure. But even though you give the tablets as a OP procedure, these are all the things you should be maintained. You should have that this 8 weeks is recommendation. Act is only 7 weeks. It should be supervised by the medical practitioners, whether she is expelling, whether she is coming back, whether she is continuing the pregnancy, whether she is having any complications, that is bleeding or abdominal pain, whatever it is. No need for hospitalization, but it has to be supervised. And they should have a registry, the tablets given, whom it was given, whether she is married or unmarried, whatever it is, the record has to be mentioned, and the consent of the patient is very, very important. Even you give the medical abortion tablets, you should have the registry and the consent of the patient. It doesn't mean that the husband's consent, the patient's consent is very, very must. And you should have mentioned where she should go for an emergency. If she is having bleeding, means your OP will be closed, where the patient will go with abdominal pain and the bleeding. So where she has to go and how she can contact the doctor, that has to be mentioned. So this medical abortion pill is good, but you have to monitor. Sometimes we have seen cases, patient was given this medical abortion pills for the gestational age, and after 1 week, the patient has returned back to the government hospital in a shock condition. After doing the ultrasound only, we saw that the tablets given was, it was an heterotropic pregnancy. The tablets from the uterus abortion products has come out, but another pregnancy was in the tube and it has ruptured and patient has become shocked. So heterotropic pregnancy, you should have in mind before giving the medical abortion pills. Please do the ultrasound and then give the pills, whatever is needed. This is that what I told, if it is an heterotropic, it doesn't mean that it should be heterotropic. Normal for the patient also, there may be no pregnancy in the uterus and it will be in the tube. Ectopic pregnancy may be there. So do the ultrasound and then give the medical abortion pills. So this is that is the fact. This is the recommendation. If it is above 9 weeks, means give with mifepristone. If it is above 9 weeks, means patient should get admitted. Only up to 7 weeks, you can give as a OP procedure. If it is above 9 weeks, give the mifepristone and followed by misoprostol vaginally or buccally or sublingual, whatever is possible. It can be given now for the second trimester also. We go with the medical management of giving mifepristone and misoprostol 200 every 6th hourly or 4th hourly. But for all these recommendations, patient has to be get admitted. But don't go with the OP treatment. This needs admission and investigations and everything. This is the treatment with the medical abortions. So what is MTP Act, how it has to be done, the medical abortions, how it has to be given, we saw. Next comes the unmarried girls and the adolescent girls. Now, as per WHO, as all of us know, the adolescence is from 10 years to 18 years. If a girl comes with the 18 years, that is, she comes with the pregnancy. Now we have this POCSO Act, Protection of Children from Sexual Offences. Now in the media, we are recently seeing many persons are going to the, mainly the teachers. So the protection of children from sexual offences came into force from, this is after that Nirbhaya incidents. All of you must be aware of the Nirbhaya incidents in the Delhi. After that only we had the Criminal Act of 2013, 2012, and this POCSO Act of 14th November 2012. What is this POCSO Act? This POCSO Act doesn't mean that it is only the rape incidences. It includes everything: penetrative sexual assault, aggravated penetrative sexual assault, aggravated sexual assault, sexual harassment, and using child for pornographic purpose, and trafficking the children in sexual purposes. Anything, they can be, whether this is not only for girls, even the boys, if they have any problem, they can come. If it is below 18 years, they can be arrested under the POCSO Act. So these are all the cases where the POCSO Act considers. What happens? Everything, minimum and maximum. What is the punishment? If it is a penetrative, 7 years, aggravated 10 years, sexual assault 3 years, aggravated sexual assault 5 years, sexual harassment 3 years, like that. For everything, now the immediate action is taken and immediate imprisonment and punishment is given. But only thing why the girls should come and tell, that is the main reason. Most of the time we tell that unmarried abortions, we don't have the records because we don't have the statistics. The girls should come and tell, then only this imprisonment. This should be known to the practitioners, and it should be known to the public, and it should be known to the adolescent. Because this POCSO Act is there, and it will be, all your problems will be solved. So this POCSO Act is a good thing, which is beneficial mainly for the adolescent girls. This is the punishment which is given. This punishment this is not only for the whoever the boys or whatever it is. If the patient comes to the clinic, even the doctors, if they tell that if the girl is under 18 years and we will not see the patient and it has to be referred to the government, you cannot tell like that. As per POCSO Act, you have to see the patient. Whether you are a private practitioner or the government doctor, first person, whoever sees the case, whether if you think that they had the sexual abuse or sexual, whatever, as I mentioned earlier, assault and everything, you have to give treatment. But main thing is that doctors should inform the police. First, you should file the AR copy. You have to inform the police, and then you have to give the treatment. If you have the facility, if you don't have a very good facilities, means then you can refer. But first, treat the patient and give information to the police, and then you can refer to whatever you want. That is for the welfare. So when a doctor has reason to suspect the child has been or is being sexually abused, and he or she is required to report this to appropriate authorities, failure to do this, the imprisonment up to 6 months with or without fine for doctors is there as per POCSO Act. So if an adolescent girl comes with a sexual abuse or any history, please put an AR copy and give the treatment, and then you can refer. Even as per POCSO Act, emergency contraceptive pills also can be given to the adolescents. Again, you can think that if you go to the police intimation, it will take more days and it will take years for the project. It is not like that. As per POCSO Act, they have the local judgment, the local committee they form, and the punishment or whatever treatment it has to be given, it will be decided as early as possible. So the POCSO rules, what are all the things you have to treat? As I told, the injuries has to be treated, whether she is an STD patient or HIV patient, and pregnancy testing is important. You have to do the test, and emergency contraceptions if needed, you have to give, and a psychological counseling. So once the girl is going for a sexual assault or rape, the post-counseling, the post-situation, the psychological problem, it is very, very difficult for the girls. So counseling is very, very important. So the such treatment as per POCSO Act, it should be free of cost, but it depends on the practitioners. So POCSO Act, it should be free from problems, and the patient should also be free from the problems. The law, previously we should want evidence, but as per POCSO Act, there is no need for medical evidence at all. If the girl comes and tells that this is the incident, that such thing happened, with that the police and the court will take action on the person who was responsible for this. So doctors, we should be very careful. If a girl with whether married or unmarried, this is POCSO Act. If she comes under 18 years to you, please have a police copy. If they want, you can have the action. If they don't want, for your safety, you can have the registry and the AR copy. If the girl is having willingly, she is having the sexual intercourse with the boy and she wants to have the emergency contraception pills, like that means as per POCSO Act, up to 12 weeks, you can go for termination. If it is beyond 12 weeks, you can form a medical board and you can do the termination. If it is beyond 20 weeks only, you need the permission from the court. Okay, so this is POCSO Act, and we have special juvenile police unit also. If the girl comes without the partner or without the parents, like that means you can have the inform the child welfare committee, and she can be kept in the child welfare committee also. But the adolescent girl should not be kept in the police station in the night. This is also one point of the POCSO Act, which I didn't mention. So if she comes without the partner or if she comes with her friends, you inform the child welfare committee and inform the police and give the needed treatment, whatever is needed. If it is more than 20 weeks, till the court order comes, don't do the MTP procedure for adolescent girls. So this is the POCSO Act. So next, this I think Dr. Vishwapriya has already told. Now we have told what are the legal issues with MTP and medical abortion pills and the POCSO Act. This permanent method for sterilization for MS. There is no need for consent from the husband. The wife, the patient can herself give the consent. And the failure cases, as she told, we have to inform the district quality assurance committee, and they will take. These are all the things which are 1A. Within 7 days, death 2 lakhs, and 30 days means 50,000, failure 30,000. These are all the amount which the government will pay to the patient and to the institution itself. So always contraception is better rather than going for a termination. So whenever you have an opportunity, even for the adolescent or married or perimenopause, give them the contraception. So thank you. This is our the World Population Day. Our theme is impact of COVID-19 pandemic on fertility. Now, as on date 2021, the world population is 7.9 billion, and Indian population is 1.39 billion, and Tamil Nadu is 1.88 crores. Thank you. Once again, I thank IMA Chennai South for giving me an opportunity. Thank you.
Dr. Sampath Kumari, one question. See, when MTP was legalized first, they said abortion on demand is a government policy in Tamil Nadu. Is it still so? On demand?
Abortion on demand means how many weeks?
No, the very first trimester abortion on demand, any married woman or unmarried adult above 18 comes, the doctors have to do it. No questions asked. Is that so?
No, madam. MTP Act we have to follow. 12 weeks means if she is a patient comes with means why she wants to the government hospital, even if she comes to private, I don't want this baby, then you can do the MTP. What is there? If the patient, the mother is not willing to continue the pregnancy means you can do it. But we have, what I want to tell is the MTP Act, whatever is needed, that has to be done. That's all. If she is coming at 26 weeks and tells I don't want the baby means you cannot do it. The place where you are going to do the MTP should be the registered.
Yes.
They should have the certificates. MTP on demand we can do, not only in government, even in private. You can do it, but it should not be a practice. If she is going to come alternate months means, then it should not be the
yes,
practice.
that's what the problem is.
Sampath Kumari, but
yes,
they will do MTP provided she is willing for a copper T insertion, because we used to do MTP and put in a copper T, not send the patient unlike in private practice.
That is not the guidelines, madam, but we are telling because patient will be coming repeatedly, no. So we are telling with the MTP and the copper T, but on demand, as Tara madam is telling, we have to do it.
And what about the confidentiality? Do we write the patient's name in the registers and maintain it? Because it's
madam, normally that is a very long procedure, madam. We should have whatever the name written, that should be on our hands. When everyone is saying means we should have some code number, but this is not followed anywhere. If my patient name is Shanti means the code number is 01. Next is 02. That will be visible to everyone. But we should have a personal report with the patient's name. But this is not done anywhere. we can have the opinion from Dr. Kalaiselvi, I think. Kalaiselvi, madam, do you have any idea? Madam, mute பண்ணுங்க.
Madam, unmute பண்ணிக்கோங்க.
See, even the forms you sent to the government, they have the patient's name and all the details of the patient.
ABC எல்லாம் ஃபார்ம் இருக்கு மேடம், பட் நார்மலா அவங்க சொல்றது பேஷண்ட் நேம் தெரியக்கூடாதுன்னு. பட் I have never seen anywhere that number இல்ல சாந்தினா 01, சித்ரானா 02. We are not following that. Normally it is there, but in MTP Act it is not mentioned, so we are not doing.
I see. And the corporation accepts only with name. That's the thing.
Yes, madam. Yes.
There's something should be done about it, isn't it? See, what is the point having confidentiality?
Very difficult, madam. In a government hospital, for example, we may be having lot of patients where to go. So it will be difficult. If we do it, it's okay. But it will be difficult to maintain. Till now, I have never seen anywhere.
Has that led to any legal issues?
மேடம், அது அவன் ஹஸ்பண்ட் கத்துப்பா கல்யாண பத்திரிக்கை நம்ம பாக்கிறது இல்லல்ல, அது மேல ஏதாவது ப்ராப்ளம் இருக்கும்ன்றதுக்காக கான்ஃபிடென்ஷியல் சொல்லிருப்பாங்க. பட் இட் இஸ் நாட் our duty, no. Yes, madam.
I think medical abortion has now reduced the incidence of the surgical MTP. So that much, you know, that post-abortal complications are much less. Otherwise, previously we used to get septic shock, abortion done somewhere, and girls used to be brought in such a pathetic state. That has all now come down.
அதுதான் மேடம், it is their rights. அதனால அவங்க வந்தாங்கன்னா நம்ம பண்ண மாட்டேன்னு சொல்லக்கூடாது. whether it is adolescent or married or unmarried, whatever it is, we can counsel her and we have to do the MTP. Otherwise they will go to the illegal places and they will go for septic abortions. That's all.
Yes, yes.
Even for adolescent, we should counsel for contraception. Sexually active adolescent girl can have even the copper-T incision. Thank you, madam.
Thank you so much, Sampath, for your wonderful talk and legal clarity. Actually, that's what actually Dr. Kanakavel also put it as legal clarity.
Yes, thank you, sir. Thank you, sir. Kanakavel, sir. Thank you.
Kanakavel. So, shall we?
Yes,
we all
madam.
had a feast of knowledge on contraception today. Excellent speakers, and we all had a very good knowledge. Gained knowledge. I thank our IMA Chennai South President for giving us the opportunity to conduct this program. Thank our State President, Dr. Ramakrishnan, and Dr. Maragadamani, our North Zone Vice President, our member, for their presence and their encouraging words. And I thank all the speakers for their crisp and excellent talks on their respective topics. I thank our members who are present today to gain knowledge. I thank Dr. Sampath Kumari, first and foremost, for giving me the opportunity to conduct the program, and she wanted it to do it. So thank you all for your cooperation. Thanks once again. Thank you all.
Thank you. Thank you, President sir, Maragadamani madam, Kalaiselvi madam.
Thank you,
Tara
Kalaiselvi
Shanta
madam.
Thank you, Sampath Mari. Thank you. Thanks.
Thank you, Yasoda madam.
Thank you, Dr. Tara.
Thank you.
Yes.
Yes, madam.
President sir, any comments today? Unmute. CVN, unmute.
இல்ல அவர் அன்மியூட் பண்ணல மேடம்.
அதான் மரகதமணி இருந்தாங்க
மேடம் சொல்லாமே.
மேடம் வந்தாளே. மேடம்.
Yeah, it was a very wonderful talk by all the speakers. They really justified their topics and a lot of new things to learn. And I am all for what Dr. Raghavan told. More of male sterilization should be promoted, and less of suffering for women should be the motto. At least our Chennai South members should take up that. And thank you, Dr. Sampath Kumari, for clear and concise talk on the legal issues. And it was a wonderful session, and we all really enjoyed it. So thank you all the speakers, and thank you, Dr. Shanta.
Thank you, madam. Thank you, madam, for your presence. I really appreciate your commitment to IMA Chennai South. I'm sure your presence there. Thank you so much. President sir, your comments?
Yeah, very illuminative talk. Enjoyed.
Yes,
Hope
sir.
everybody benefits. Thank you.
Thank you very much. Thank you all. Thank you.
madam. Shall we leave?
Yeah, I'll close this session.
Kanakavel sir, thank you.
Kanakavel, ஆளிய காணோம். Kanakavel.
அவர்தான க்ளோஸ் பண்ணனும்.
இல்ல அவருக்கு ஏதோ வேற ஏதோ மீட்டிங் இருக்கு மேடம்.
சரி மேடம். Thank you. பார்க்கலாம்.
Thank you. Thank you.
Thank you, ma'am. விக்னா லீவ்னே வர மாட்டேங்குது இதுனா மேல வரும் எல்லாரும் போயிட்டாங்க தெரியும் அது எனக்கு